So Dr. Armand Henderson is a general internal medicine faculty here at the University of Miami. He currently serves in a hybrid role of a hospitalist, educator, and community organizer. He completed his medical school at Meharry Medical College, followed by internal medicine training at the University of Miami Jackson Memorial Hospital, and obtained his MBA from the Vanderbilt Graduate School of Management. He holds several leadership positions in the community, including the Director of Health Programs for Dream Defenders and the founder of the Dade County Street Response. Most notably, he has had multiple media appearances on CNN, MSNBC, BET, and on the Netflix documentary called Convergence: Courage in a Crisis. Recently, he has been active in responding to vulnerable communities since the start of COVID-19, particularly working with those that are unsheltered in Miami. His focus areas are climate change, disaster preparedness, street medicine, gun violence, and social determinants of health. Welcome, Dr. Henderson.
Thank you so much for having me. It is an honor to be here presenting with you all, and I'm excited to get started. So thank you so much, Dr. Grant and Dr. Weiss for having me. So I'm going to just go ahead and get started. The topic of my talk is called Social Determinants of Health in Action. And I want to emphasize the inaction part because that's the part that we really are going to dig into today. That was a good introduction. I just wanted to show you some pictures of me in medical school. Great. Meharry was great. So there are a couple steps within the social determinants of health and action. The first step is to know the history, the step and advocate. And the third is to actually. So I'm going to go over, some of the other steps, but the one step I'm really going to focus on today is the action part, as I said. So the first part about the history, I think we get a good, understanding of this, especially in light of COVID-19 and a lot of turmoil country years. And I gave a small talk about this, about the origins of white supremacy and things of that nature and how it interacts within the field of medicine. Racism in general, of course, it is levels to it. There are multiple different levels. There's systemic, community, institutional, interpersonal, and interpersonal, and all of these things lend
Armen, unfortunately, you keep freezing and breaking up your audio.
That there are disparities in okay, so I'm going to stop my video. Hopefully that helps out. Can you hear me now?
It's better, thank you.
Okay, great. So I was saying that there are multiple levels to racism and at play that lend to the decreased life expectancy of our patients. Tuskegee, J. Mariel Sims, the father of modern oncology, which I wrote an article, a patient that I met at the University of Miami, who knew this individual personally. There's forced sterilizations. I'm from Philadelphia, Holmesburg prison population experimentation. All these things are a part of the history of racism in medicine. Of course, there's also the syphilis study as well. And again, I'm not going to spend a lot of time here. I'm just going to kind of breeze through it. There's also a new research article that was published in 2016 that talked about Tuskegee as one of the major causes of health disparities in the United States and led to the mistrust in the medical field amongst Black people today. And so medicine is deeply rooted in the slave trade, and which we know. We're learning more and this is Dr. Cornelius Road. experience both at Harvard doing research as the head of the chemical weapons division in the military as well. And so the effects of the history of medicine is mistrust of the system, implicit bias, the rate.
It seems like we have lost him, Dr. Weiss. I am going to try to call him and get him back on.
You know what? Maybe he can go to a different location, and we can he can continue after this. We'll go to the second speaker, and not to lose time, and then he can come back on after that. So, Dr. Grant, is our second speaker ready to go? That would be Dr. Grazette. Is Dr. Grazette here?
Yes, she is.
See. Seeing her logged on, Dr. Weiss.
Yeah, she's on as the kiosk. Dr. Grazette?
Yeah,
We'd be honored, Dr. Grazette. Thank you for being here. Can you start your, we'll continue your full 30 minutes, and then we'll stop and then go back to Dr. Henderson. Is that all right with you?
sure.
Thank you. Okay, Dr. Grant, can you introduce Dr. Grazette?
So Dr. Luanda Grazette is an associate professor of medicine in the Division of Cardiology who specializes in advanced heart failure and transplantation. Dr. Grazette completed her dual MD MPH degree at the Harvard Medical School, followed by internal medicine residency training at the Massachusetts General Hospital, and her fellowship in cardiovascular diseases at Emory University. She ended her training back at MGH, where she completed her heart failure and transplantation fellowship. Before relocating to the South, she served as the co-director of the Advanced Heart Failure and Cardiomyopathy Division at the University of Southern California, and was the program director of the Heart Failure Fellowship. She has authored and co-authored multiple peer-reviewed manuscripts in some of the most prestigious journals, including the Journal of the American College of Cardiology and the European Heart Journal. Dr. Grazette, we're excited that you're now in Miami and look forward to your presentation.
Can you guys hear me? Can you?
We can
Okay,
hear you.
great.
We need to see your slides.
Okay. I'm having trouble with the share. Hold on a second. Okay, can you
We're
see the
good.
slides now?
Yep,
Okay.
everything perfect. Thank you, Dr. Grazette.
Of course. All right, so without further ado, thank you, Jelani. That was a very kind invitation and for introduction. And unless Dr. Weiss has revoked it, I think I'm a professor at this point. So I'm gonna go ahead with my first slide. Sorry, I'm in clinic on one of the kiosks, and there we go. Okay, so I was invited to do present a clinical scenario, and I decided to present one that I saw with a lot of my colleagues, who hopefully some are in the audience. This is a patient that presented to my clinic with no prior history of cardiac disease, who was referred for acute onset of congestive heart failure. Unlike many of my patients, she had no typical risk factors, no history of diabetes, hypertension, coronary disease, no family history of dilated cardiomyopathy or sudden cardiac death, no previous history of intoxications or exposure that were worrisome, minimal alcohol, and pregnancies that were uncomplicated. And I include the pregnancies because we now recognize in cardiology that eclampsia and pre-eclampsia increase the risk going forward for adverse cardiac events throughout life. She did have a number of atypical risk factors, however, which included a single episode of reversible LV dysfunction associated with tachycardia and emotional stress, which sounds like she likely had a stress-induced cardiomyopathy. She also had a history of phenuremy used for weight loss, which was remote, but she did use it for 4 months. And most importantly, and germane to our talk, she had a history of a recent COVID infection. So with regard to the recent COVID infection, about 2 months prior to her clinic presentation, she tested positive for COVID. She had minimal URI symptoms and would not have suspected that she was positive or infected if it weren't for the fact that she had a close contact who was ill and tested positive for COVID. She had no fever, no dyspnea, never lost her sense of smell, never had abdominal pain. And after that week, she returned to her vigorous exercise program. She's a person who described herself as having been in the best shape of her life and really is an avid Peleton user. 1 week later, however, after starting her exercise program, she had really pretty acute onset over the course of about 48 hours of severe fatigue, which she described as heaviness and dyspnea, unable to walk up a single flight of stairs in her home, and presented to a local cardiologist, friend of the family, who did an outpatient echo and told her that her ejection fraction was 10 to 15%. She went to St. Elsewhere, where she was started on medication and had a preliminary cardiac evaluation, which included a cardiac cath, which showed no evidence of coronary disease and an ejection fraction of 20 to 25%. And she was discharged home with a life vest and lots of questions. So by the time we saw her in clinic, she was normotensive. Her heart rate was a little bit elevated at 108. She was afebrile with good SATs. As you can see on her EKG, she had low voltage and a good bit of ventricular ectopy. Both are signs of an unhappy heart, a myopathic heart. She had a lot of pertinent negatives. We generally look at EBV and CMV in patients, and sometimes adenovirus as well, with patients who turn up with unexplained cardiomyopathy. Her rheumatologic evaluation was within normal limits. Nothing was flagged. She had no evidence by enzymes of ongoing myocardial death and damage. Her SED rate likewise was in normal limits, as was her high sensitivity CRP. D-dimers were also normal. So the plan at that point was to further distinguish and understand her cardiomyopathy and to clarify her arrhythmia burden. So a CMRI and a Zeo patch were ordered. However, she turned up 3 days later to the emergency room with severe abdominal pain. And abdominal pain is one of those symptoms of cardiogenic shock and low output that's frequently under-recognized. And I say cardiogenic shock because although at her original presentation, she was normotensive, when we took her to the cath lab soon after her admission, you can see that despite the fact that she had no overt evidence of volume overload, she wasn't particularly congested. She had a low right atrial pressure and her wedge was only 20. Her cardiac index was 1.23, with the normal range being between 2.6 and 4.2. Frequently, patients who have indexes below 1.5 are pretty moribund, sort of difficult to rouse. And sometimes we start to believe that that's how patients always have to appear when they're in cardiogenic shock. But behold the power of youth, and also the power of vasodilator drugs. In the current era where we have very potent, effective vasodilator drugs that we start patients on as outpatients, the usual clinical findings of cardiogenic shock may be underrepresented. And so it's important to remember that a lot of folks are walking around with cardiogenic shock and who have perfectly warm extremities. Even with regard to her metabolic evaluation at that time, although her BNP was elevated at 4,100, I'm certain many of you, most of you have probably seen BNPs much higher than that. Her lactate was 1.1 and remained normal throughout most of her hospitalization. And she had good urine output. Nevertheless, because she was in cardiogenic shock, she went to the CCU, where she was resuscitated over a long period of time with pressors and inotropes and some fluid resuscitation while we waited for the results of the endomyocardial biopsy, which was also performed at the time of the right heart cath. Now, the significance of the endomyocardial biopsy is that the first suspicion in a patient coming in with fulminant heart failure with no clear etiology is, especially in a young person, is generally myocarditis. And although she didn't have any of the signs in terms of enzyme leaks in troponin or CPK, we really wanted to rule that out or assess it because the treatment regimen is quite different for myocarditis versus cardiogenic shock due to other intrinsic types of cardiac damage. So we did get the biopsy back, and it showed cardiac muscle with myocyte hypertrophy and patchy mild interstitial fibrosis, no amyloid, no granulomas, no evidence of infection. So this is basically the endomyocardial biopsy that we see with almost every patient who has dilated cardiomyopathy. One of the first things that the heart does under stress is to hypertrophy the myocytes. And then as the dilation continues and the heart begins to remodel, there is interposition of fibrous tissue. And you can see the fibrous tissue there in sort of the pale pink, which we really don't like to see on endomyocardial biopsies, and these sort of puny, lethargic looking myocytes that should be more densely packed and should have a heftier appearance. So not a healthy looking heart, a sick looking heart, but no frank evidence of myocarditis. And at that point, we were struggling because despite resuscitation, the patient was also continuing to struggle with ongoing tachycardia and arrhythmias. And we debated and did a bit of hand wringing with regard to whether or not to give her immunosuppression in the absence of a frank diagnosis of myocarditis, and finally opted to do so. And it's actually after we started treating her with steroids, which did over time, we think, contribute to her heart rate starting to stabilize, we were able to finally get the cardiac MRI. Prior to that, her heart rate had actually been too high to allow for the gating of the images. And here you can see what's called delayed enhancement. So delayed enhancement with gadolinium is a phenomena that occurs when there is heterogeneity in the extracellular fluid of myocardium. And this heterogeneity can exist because of fibrosis. It can exist because of inflammation. And basically what happens is that in the areas where there is this increase in extracellular fluid. The gadolinium tends to, in a way, sort of get hung up. And you can see these sort of bright subepicardial enhancements inferiorly and on the lateral wall, which were read by the radiologists as consistent with myocarditis, and we recognize that to be the case as well. So what do we know about COVID in the heart? Actually, after the years that we've had, I'm bringing Coles to Newcastle. In some way, we know a lot about COVID in the heart in terms of the acute infection. We know that there can be acute myocardial injury and myocardial injury that in many ways apes coronary ischemia. Myocarditis can happen, although rarely, as interestingly enough, myocarditis in the setting of COVID infection, whether it's difficult to prove or not present, it's not clear, because the diagnostic criteria for myocarditis frequently require a biopsy, and patients in the acute setting of an acute COVID infection are less likely to have biopsies. But cardiac fibrosis, arrhythmias, endothelial dysfunction, of course, we are all too familiar, unfortunately. The dysautonomia that occurs during and after, and thrombotic events that occur mostly during. All of these may contribute to the morbidity and mortality of COVID-19, and there is excess representation of basically cardiac adverse events in patients who actually succumb to COVID-19, and patients who have prior risk factors are, of course, as we well know, at more risk of having events with an acute infection. We have, over the course of the last few years, come to understand a bit more about what happens. Although the ACE2 inhibitor is pretty well represented throughout the body. It is, I'm going to actually go back to the prior slide. It is most common in, of course, the lungs and in the intestine. But there are also ACE2 receptors particularly on the pericytes and the myocytes themselves. And the transmembrane protease that is believed to be necessary for cleaving the spike protein. When co-localization studies have been done to look at the highest rates of co-localization for basically the ACE2 receptor and the transmembrane protease, the second highest co-localization is actually seen in the heart after the lungs. And so there may be direct damage to the heart from the virus itself, in addition to the cytokine storm, which was implicated primarily before. In addition, the parasites, which are adherent and sort of interspersed along with the endothelial cells, may contribute to this increased avidity and tropism of the virus for the heart. And all of this may contribute to the damage that happens during the course of the acute infection and possibly ongoing damage afterwards. So myocarditis and arrhythmia account for a very high proportion of excess events with acute infection. And although myocarditis has gotten, I think, probably the most attention recently because of an association of myocarditis that ended up actually being rather small overall with one of the vaccines, myocarditis does occur with the acute infection. But if you look at the scale compared to arrhythmia, which is the most common cardiac event that occurs with both acute and post-COVID associated events versus the scale for myocarditis. You see that myocarditis is actually pretty rare. So long COVID, what are the things that are sort of generally understood or generally thought about long COVID? Well, one of the factors or one of the characteristics that is common in men, if you see myocarditis, the myocarditis is generally associated with the cytokine storm syndrome, and it's more likely to occur in patients who have had a severe infection. And the surrogate that's used for severe infection in most studies is patients who were hospitalized, and patients who have pre-existing heart failure have increased risk, and studies that have documented the onset of de novo heart failure are pretty rare. Now, when you think about all of these criteria that I've just mentioned, none of them actually pertain to the patient that I just presented to you, which raises the question of, well, is this a unique case? Now, there has been another syndrome that has been described for women basically in the prime of life, age 30 to 45, which is related to kind of a excess or inappropriate tachycardia, and the susceptibility is susceptible, or as I mentioned, females prime of life, and it really hasn't received a lot of study just yet. But one of the suggestions from a recent guideline type recommendation publication is that these symptoms may be related to deconditioning, and deconditioning on the grand scale, meaning deconditioning because patients may be not exercising and not moving around as much when they have COVID, and then deconditioning on the small scale in terms of cardiac deconditioning and atrophy and decreased stroke volume, similar to what's seen in a POTS syndrome, which again doesn't sound a lot like our patient. So is she a unique case? Well, some of our colleagues who I hope many of you recognize, who were involved in the care of this patient, also had this question. And basically just going through the cases from myself and Dr. Josh Hare, have a growing series of patients who are in this category of being young, fit women who post-COVID have had some form of de novo cardiac dysfunction. And the two columns that I want you to pay attention to are the age, and you can see the age range here between 20 and 50, and also the cardiac, the pre-morbid conditions, which are actually pretty few. And I hope along with all of you will be waiting to see what they come up with as they move toward preparing this data for abstract submission. So what are the possible implications? What are the possible mechanisms underlying this type of phenomena? Well, of course, with the initial COVID infection, there is myocardial injury, direct myocardial injury that can happen. And in the same way that direct myocardial injury in some form or fashion is the nidus for developing heart failure with time, it's possible that that sort of injury can lead to some of the long-term complications of dysrhythmias and heart failure, and perhaps increase atherosclerotic risk. Now, and maybe lead to persistent cardiac injury. Now, I say perhaps because this is still, sort of part of the undiscovered country. We're still understanding what it means to be post-COVID, and a very, very nice series that was just published about a month or so ago, where they looked at an extraordinary number of patients who were taken care of in the VA system who had positive COVID tests between March 2020 and January 2021, and compared those patients with the contemporary cohort of patients with no evidence of a COVID infection, and also with the historic or pre-pandemic control population. The average age of the cohort, COVID positive cohort, was 61. It was 90% male, essentially. It is the VA, and 71% Caucasian, white. But because of the sheer number of patients that they saw, there was actually pretty good representation of other groups. So there were about 27,000 Blacks, about 17,000 women, and 8,000, and they, sort of cohorted together Asians and Latinos. So they actually were able to see a lot of people. And if you look to the left, where, excuse me, the highest incident, the highest burden post-COVID is with atrial fibrillation, which is equaled by heart failure, both at a rate of about 12 per 1,000 excess events. So that's pretty extraordinary. And one of the authors in an editorial also commented on the fact that this increased risk occurred across the board in all study subgroups. So in patients who were young, and patients who were old, and patients who had premorbid conditions, and patients who did not have premorbid conditions. And so this is, sort of a really good, not necessarily first hint, but a really good hint that SARS-CoV-2 may precipitate de novo cardiovascular disease. So what's the way forward? The way forward is that we are going to have to begin to clarify this, because we know a lot about what happens with the initial COVID-19 myocardial injury. We know a bit about the immediate cardiovascular sequelae. We're learning more as we go, but we currently know a bit about this. But about the long-term cardiovascular outcomes, that's where we have to continue to gain knowledge. And so we can, basically, one of the things that needs to happen, or one of the things that we do, is to consider this as a risk factor, and the history of COVID-19 probably needs to become a cardiac risk factor that we inquire about, the same way that we inquire about family history or smoking, as we start to do studies to understand what the long-term implications and long-term history will be. Hopefully, we will also at the same time be able to understand how to mitigate many of these long-term outcomes. So to end on a somewhat positive note, I just wanted to mention that this patient that we saw, who spent 20 days in our hospital, 17 of which in our cardiac intensive care unit, was discharged home in good condition, and her EF a month later on a follow-up echo is 30 to 35%, which is quite an improvement from the 10 to 15 that she was initially told about in the 20 to 25 when she was seen at St. Elsewhere. Is she back on her Peleton? Actually, no. I've encouraged her not to begin vigorous exercise again, because again, on May 3rd, the ACC released the expert consensus on what to do with these patients who've had myocarditis or serious cardiovascular sequelae of COVID-19. And one of the recommendations that is quite important is that for those patients who've had myocarditis or other myocarditis type of involvement, depressed function, those patients should not exercise for 3 to 6 months, and then should have a graded return to play after that. What's the reason for that? Part of the reason for that, frankly, is ignorance. We don't know a lot about what the risks are for these patients. What we do know is that for athletes, myocarditis is a common cause of sudden cardiac death. Now, that has to be taken with the caveat that, and healthy, when we're talking about athletes, we're talking about young athletes in terms of the people who have been studied and tested, don't have lots of other reasons why they're dying. And so there may be an exaggeration of that that statistic, but an abundance of caution as we go about understanding how to risk assess these patients. That is the recommendation. I'm going to wrap up now and
one minute, Dr. Grazette.
Sure.
Thank you. You have 1 minute.
Oh, sorry. Yeah.
Okay.
So I'm wrapping up right now, and I encourage you for any further information to visit the American College of Cardiology COVID-19 hub, which has an abundance of good information. And I hope that I haven't done to you in this talk what happened to this poor gentleman in the middle of the graphic here. He seems exhausted. Thank you for your attention.
Dr. Grazette, thank you for that fascinating grand rounds, excellent discussion, and you scared me a lot, as I can tell you, because of the unknowns. Is there any way to identify a fingerprint, either a serologic fingerprint of the types of antibodies that are present in these specifically women that go on to develop the heart failure, or do we know anything about the subtype of COVID-2 that was involved in these particular 12 or so women that you identified? And I noticed most didn't get vaccinated, although a couple did in your table. So a lot of questions, and if there's a brief answer, if not, we can talk later.
So most of them were Delta, but to be honest, we the last two and the ones that were most severe were actually Omicron. In terms of other diagnostics, I mean, I tend to get BNPs on everyone basically as a NT-proBNP as a good sensor of cardiovascular stress. And if that's not a baseline, or if it's increasing, that tells me to dig a little bit deeper. But I think it'll be some time before we have things that are more specific than that.
Thank you so much. What an excellent presentation. And I see it's echoed by many in the chat as well. So thank you, Dr. Grazette. At this point, we'll return back to Dr. Henderson. If you could take over the screen, Armen, and you can just continue where you left off. Thank you.
Okay, great. So I apologize. I was having some technical difficulties, but I think we should be better now. Yeah, so my presentation again was about the social determinants of health in action. I basically started talking about the history of racism in medicine, basically outlining the fact that there are 3 steps to undertake the social determinants of health in action. The first step is to know the history. The second step is to vote and advocate responsibly. And the third step is to actually take action. And so I'm really going to focus a lot of my talk on the action, but just for a brief terms to define some terms. Health disparities are preventable burdens of disease. I think we know exactly what the definition is, and we see a lot of these health disparities in practice. Racism has exacerbated health disparities for a number of reasons. In my opinion, there really has not been really concrete plans to address them. A lot of people have talked about how to address them, but on a federal level, let alone on a local level. And so what we're doing within Dade County Street Response with the medical students embedded in the residency is really taking on social determinants of health and action on a local level. So again, social determinants of health are conditions in the environment in which people are born, work, live, play, and these really affect people's quality of life and really their life expectancy. And so climate change, crisis, disaster, an economic downturn, or even COVID-19 could be considered like a crisis, a pandemic in itself. These exacerbate social determinants of health as well. These are just some examples of what some of the social determinants of health are. And I just want you to take into consideration that all of these are really outside of healthcare, or really, well, even healthcare, are controlled by politics, and specifically on a local level, local politics. And so it's important that we recognize how they're controlled and because they have a bearing on the patients that we serve as well. In this presentation, I talk about capitalism and where it's gone wrong, and what it has to do with you basically is that physicians now, traditionally, I would say about 20 years ago, physicians could open up a practice and specifically primary care physicians, but now we find ourselves as employees of corporations, not so much at University of Miami, but more so like Hospital Corporation of America, and which is the largest owner of hospitals in the country. And because of that, they're more concerned really with output rather than quality of care. And so where does that leave us? And I'm going to talk about where that leaves us in general. But step 2, as I said, in social determinants of health and action, is to vote and advocate responsibly. We can't vote for a party or a candidate that if you're really concerned about the life expectancy of our patients, and we know that social determinants of health are controlled by politics, then we can't say that we care about the social determinants of health and vote for a candidate or a party that is totally against or that denies access to people to those social determinants of health, and in response, what causes a lot of the decreased life expectancy of our patients that we serve. And I guess an example of this is right now we're in a battle about Roe versus Wade with the recent leaked opinion of the Supreme Court. And the reality is that we voted for an individual who decided to put in the Supreme Court justice who thought that this was a good idea. And what happens is our patients, particularly our poor, our Black and brown patients, are going to suffer the brunt of what that decision will be. But hopefully we fight for what's right for our patients. So there are also disparities or policies that have created disparities in America as well. One of those is the 1994 crime bill. And that is one of the causes of the majority of increase in not just prisons and the prison population, but also of police in our country as well. In this presentation, I talk a lot about the disproportionate harms that it caused amongst the Black and brown communities, and try to like kind of connect it to how that affects our patient population. Basically, you know, when people are behind bars, they're denied opportunities, they're denied access to social services, and denied access to the social determinants of health, which again are the reason why we have a decreased life expectancy amongst Black and Brown populations who live in low income communities. So, yeah, I mean, politics are very important when it comes to the social determinants of health, specifically local politics. And these are the things that I'm particularly interested in with the election of our new mayor, who seems to be very forward thinking in a lot of the problems that low income and Black and Brown communities face. And I think as a result of us electing someone like her, Mayor Kava is who I'm talking about. These are the individuals that are really going to drive a lot of the outcomes that we see on a local level that affect our patient population, particularly those that live within a 5-mile radius of the hospital. And so I was engaged in this Young People's Forum in which I moderated, and you know, we got to hear firsthand from a lot of the political candidates. So as I said, the first step in social determinants of health in action is to know the history. The second step is to vote and advocate responsibly, to know how politics interact with the social determinants of health. And step 3, as I mentioned, where I said I'm going to spend the majority of my time, is really around the actions. The step 3 is to actually take action. And so, of course, what I did when I first came to Miami is that I joined a social cause. I started organizing with an organization called Dream Defenders, but there are also other organizations across the country that are doing similar work. And the connection really is within Dream Defenders and other organizations, is that when they pick up social causes and social justice and the call for rights of Black and Brown people, what they're really saying, in my opinion, is they want to expand access to the social determinants of health, particularly amongst Black and Brown populations. And so I think that you know, organizing with a group called Dream Defenders really opened my eyes to how social justice movements really interact with healthcare and with the health of our patients through the social determinants of health. And so Dream Defenders in particular was started after the death of Trayvon Martin. Some of the campaigns that I've worked on with Dream Defenders are Free the Block, the Voting for Returning Citizens, the starting of a trauma recovery center, and other things I'm going to mention as well. And so these are some of the people who are within Dream Defenders. As you can see, it's mostly Black and Brown, mostly women, and it's throughout the state of Florida as well. I was going to play this video, I'm not, but basically there is a connection between the social determinants of health and medicine. So again, as I said, the manifesto that Dream Defenders put forth is really just repackaged social determinants of health, in which they talk about freedom to be, freedom from war, violence, and environmental destruction, freedom of movement, a free flourishing democracy, freedom of mind, freedom from poverty, and freedom from police and prisons. And these are the things that they organize around throughout the state of Florida. Again, my work with Dream Defenders really focuses on the Trauma Recovery Center, the participatory defense, in which we get poor and disenfranchised people who are facing a lot of time behind bars out of jail. We talk about the history of racism in medicine, and then my view about being a community physician as well. But the CDC also defines the role of public health agencies in addressing inequities. And I think that this is where my work connecting University of Miami and UHealth to the community organizations that serve people in places like Liberty City, Overtown, Opa-locka, Miami Gardens. And they talk about these 10 roles, which I think are very important. And they start to define what anchor organizations and what healthcare organizations and other public health agencies should be doing to address inequities around the social determinants of health. And so some of them are monitoring health status to identify and solve community health problems, which I think that we do, diagnose and investigate health problems and health hazards in the community, which I think we're starting to do as well. Inform, educate, and empower people about health issues. These are some of the things that we do as well. Mobilize community partnerships and action to identify and solve health problems. And this is where we focus, where I'm going to focus a lot of the work that I'm doing on talking about today. But there are other ones as well, which I think are similarly important. to enforce laws and regulations around code enforcement, environmental laws, to link people to needed health services and ensure the provision of health when care is otherwise unavailable, and other ones as well. And so the CDC on the federal level has started to define exactly how to address these things. And I think, using the CDC as a good toolkit in trying to figure out what programming should be put forth, et cetera, I think is important, not just in putting forth programming, but also in developing education and things around it for students that are going to come out of it. And that's also where we focus as well. And so I started an organization while I was in residency called Dade County Street Response, because I saw the need for the reconnection of physicians, particularly physicians in anchor organizations in low-income communities. And the reality is that University of Miami is a wonderful institution. We have a lot of great things going for us, but the reputation within the community, and this is what I've heard firsthand, is that people come, they want to do research, but there's really no connection with the community. And so I started this organization because I felt disconnected from the community that I was in and serving. And it started really around doing workshops around Stop the Bleed and CPR and violence mitigation. But what it turned into was a whole service model of an organization, which I'm going to dive more in right now. And so Dade County Street Response really has become a street medicine team, which I'll talk more about, an urgent care center, which is free for people who live in Liberty City, community programming around volunteerism and education and advocacy, and a disaster relief team, which focuses on vulnerable communities during hurricane season, June through November as well. And so I'm going to, pretty much dive really into these things. But the reality is that even students within the University of Miami, medical students in particular, have really started to ask themselves, what connection do I want my university that I'm associated with, that I'm affiliated with within the community? And I think that the letter that the Student National Medical Association really spoke to the fact that they wanted to be more connected to the community that we serve, and the university took some bold steps in creating the Racial Justice Task Force to address some of those concerns, in which I'm a part of, and so we'll see how those things come to fruition. And people got up, they protested, and they said that things are not right in the community, that they wanted more connection throughout the university and at Jackson Memorial Hospital as well. And so good things were happening, and I thought that it would be a good way for the university, for my role as a hospitalist and now director of health advocacy for the university, to connect it to the organization that I founded a couple of years back while I was in residency. And so right now, our programming is not just programming that's on the ground, that we do good work on the ground amongst vulnerable populations, but we're also integrating it within the medical education of medical students and of residents as well. We are a free and charitable clinic of South Florida. We're also recognized by the Department of Health as a free clinic. And so our liability is none. And so that encourages other physicians, specifically you on this call, et cetera, to join our cause and to get involved as you can. And we'll be presenting some of the findings and some of the ways in which we are integrating Dade County Street Response within the medical education on the national level, in which we're going to present some of the recommendations to the American Association of Medical Colleges, their conference coming up later on this year as well. And so to pretty much dive into the programs, I want to make sure, oh crap, I'm running out of time. But the street medicine team, I think, is one of the most integral programs that we run. It was started by a medical student named Daniel Burkholz. He is a third year, rising fourth year medical student applying to residency. He wants to stay at the University of Miami. He's been the mastermind behind bringing street medicine, which is not just going toward unsheltered people and doing blood pressure checks or diabetes checks, but it's also a whole case management structure in which we provide services to thousands of patients who live on the street in Miami-Dade County. And the street classroom model that's being developed and Daniel right now is in Seattle at the Street Medicine Conference, in which we hope to bring the entire conference to Miami, really is created due to the lack of coordination of services amongst unsheltered people. It's a 7-day operation. Again, we see thousands of patients, and it's really critical to the work that we do within Dade County Street Response. And so I wanted to show you all just how detailed and thorough that our street medicine team is, in which there are people, hundreds of volunteers from the medical school and that are medical students that do integration, development, operations, and patient care on so many levels, and just touching so many people throughout Miami-Dade County. It's an integral program, not only just to University of Miami and the students that serve in the organization, but also to the patients that we serve as well. And so it's got a lot of recognition recently, and again, the students are doing wonderful work. And we hope that we continue to not only just publish papers and to talk good about the good that we're doing, but to also expand the work to other parts of Miami-Dade County as well. And so this was a foot washing event that we had. The free urgent care, we have partners with an international organization called AmeriCares. Again, it's open now. It'll be integrated into the internal medicine program, medicine, pediatrics, psychiatry, and all the emergency medicine as well. So we're doing good work there too. The Trauma Recovery Center is the work that we do directly with Dream Defenders and other organizations in the community. And we're creating a hospital-based violence intervention program with Writer Trauma Center and the creation of a consult team that we're implementing soon as well, in which we treat gun violence not just as a symptom of people who are inherently violent, but as a symptom of society in general. And so I look forward to talking more about that in the future as well. The other program that we have, and I know I'm running out of time, Dr. Weiss, is this Alternative to 911 Mobile Crisis Team, which is also a collaboration with Dream Defenders. Our number is 1-866-SAFE-MIA, in which we respond to mobile mental health crises using a van. People call us, we'll be there, et cetera, in which a medical worker, a therapist, and a security person shows up instead of the police. We have an anti-racist, curriculum that we put forth that we hope to integrate into the Masters of Climate Science that has just been started. And we also have the disaster relief team. And so the reality is that we have a plethora of programming that in which research is not first, it's programming first. It's the service that's second, education is second as well, and then it's research after that. And we believe that if on a local level we employ these type of strategies, not only will they be integral to the and a part of eliminating the limited access of social determinants of health to our patients, but it also will create a model of education and social change that we see not just on the community level, but within the university as well. So I look forward to talking more about our programming, and thank you so much for having me today.
Thank you, Dr. Henderson. That was an extremely important and informative vignette. We appreciate it very much, and I'm really inspired by you, and as I think we all are, to go out and do more to really correct as many issues as we can about racism in medicine and in society in general. Many of us have clinic to go to, but I will leave the chat open and the discussion open for anybody who wants to talk to Dr. Henderson or ask him some questions. But those of us that have to run to clinic, apologies, and thank you both, Dr. Grazette and Dr. Henderson, for these beautiful grand rounds.